Hey guys, it's Olivia. Welcome back to your endocrine chapter. In this section, we'll be discussing hypopituitarism. So if you've been following this chapter and a couple of other videos, we've talked about causes of hyperpituitarism, what happens when you have too much growth hormone or too much prolactin, let's say. But in this video, we'll be talking about hypopituitarism, where you're having underproduction of the hormones that are usually made or released by the pituitary gland. And the first cause of hypopituitarism that we'll discuss is K.A.N syndrome. And the cause of K.A.N syndrome is when your pituitary swells during pregnancy. So during pregnancy, your pituitary is going to enlarge, mostly because of the increased number of lactotrophs, which are those cells that secrete prolactin. Prolactin levels, of course, are increasing during pregnancy as your body prepares to make milk when the baby arrives. So those increasing lactotrophs are going to cause the pituitary to enlarge. When the pituitary enlarges, it then becomes more vascularly dependent, right? Because just like a tumor or a cancer that's growing is very dependent on its vascular supply, so is the pituitary. So when we have this enlarged pituitary in pregnancy, we're very vulnerable to lack of blood flow, which can often occur during postpartum hemorrhage. So if a woman gives birth and she bleeds a lot, there can be a sudden decrease in blood flow to that pituitary, which we've already mentioned is very vulnerable because of the increase in size. This can lead to ischemia, and that will lead to the pituitary infarct that, of course, can cause some of our pituitary tissue to die. As our pituitary tissue dies, that is what is going to lead to our hypopituitarism, and in K.A.N syndrome, this is irreversible. This will present most commonly with a prolactin deficiency. So like we mentioned, those lactotrophs are going to be the cells that have multiplied most rapidly during pregnancy. So those are the cells that are most vulnerable in K.A.N syndrome. So most commonly you'll see a prolactin deficiency when those lactotrophs die. The symptoms of prolactin deficiency are lactation failure and amenorrhea. You might see lower levels of other hormones, usually secreted by the anterior pituitary, like thyroid stimulating hormones. If you have a decrease in TSH, you might have the hypothyroid symptoms, cold intolerance, weight gain, bradycardia. A diuretic hormone, that might be low, so this could actually cause diabetes insipidus, and this is a great association to be aware of on test day. Could cause a hypernatremia with diabetes insipidus. And then how you would diagnose K.A.N syndrome is you can usually see an infarction of the pituitary on a head MRI. You might see an empty sella turcica. That might also occur. So if you look over here where you think the pituitary might be, you can see we just have some of this anechoic black fluid, and that is going to be one of the key indications that you might have K.A.N syndrome. Additionally, you might see decreased levels of all those hormones we talked about secreted by the anterior pituitary: ACTH, TSH, FSH, LH, growth hormone, prolactin, or ADH. ADH, of course, comes from the posterior pituitary, but can also be low in K.A.N syndrome. And then treatment, this is irreversible because we had this infarction. It is irreversible. So we're going to have to treat our patients with hormone replacement, and we're going to have to do the job of the anterior pituitary since it has been permanently damaged. Okay, the next cause of hypopituitarism that I want to talk about is empty sella syndrome. And in empty sella syndrome, what's basically happening is you have some cerebrospinal fluid that is compressing your pituitary, causing it to not function. So you might see this enlargement of the sella turcica because as the sella turcica is enlarging, there's more CSF that can leak in and fill it. When there's more CSF in the sella turcica, it can press on that pituitary, causing compression, and that can also cause atrophy, which will lead to the hypopituitarism. It's commonly associated with idiopathic intracranial hypertension. And if you understand that idiopathic intracranial hypertension is associated with increased pressures in your spinal column, increased CSF pressures, that should make sense to you how this increased pressure could make it more likely that CSF would leak into the sella turcica and then compress our pituitary because of that increased pressure. You're going to diagnose empty sella syndrome again with imaging. So you might see this empty sella turcica on MRI. Remember, you can also see that in K.A.N syndrome. So it's going to be really important for you to distinguish between these two, usually with a history. If a patient didn't have a postpartum hemorrhage, it's going to be unlikely they had K.A.N syndrome, right? We usually don't need to treat if our patients are asymptomatic. If they become symptomatic, of course, you can do things like hormone replacement to try and compensate for that, but a lot of them are asymptomatic. The next cause of hypopituitarism that I want to talk about is pituitary apoplexy. And this is going to be another hemorrhage or an infarction of the pituitary. We talked up here about how postpartum hemorrhage is often a cause of ischemia and decreased blood flow to the pituitary, but in this case, this hemorrhage or infarction often occurs with an existing pituitary adenoma. The presentation is sudden onset severe headache because we're having this very sudden hemorrhage or infarct in our brain, so we can have a severe headache with that. Bitemporal hemianopia. So anytime you have a pituitary adenoma or a mass in your pituitary that compresses on that optic chiasm, that can cause this bitemporal hemianopia where you lose your peripheral vision on either side. Altered mental status can also occur here. To diagnose pituitary apoplexy, we can order a head CT. We might see an intracellular mass, we might see a hemorrhage, and those would be great clues to let us know that we're talking about pituitary apoplexy here. And then we treat it with corticosteroids and possible surgery. So this treatment's a little bit different. And then the final cause of hypopituitarism that I want to talk to you guys about is craniopharyngioma. And craniopharyngioma is a benign tumor of Rathke's pouch derived from the oral ectoderm. If you remember from embryology, remember Rathke's pouch from the oral ectoderm is going to be cropping up to create our anterior pituitary, whereas the posterior pituitary is going to be a down cropping from the diencephalon in the brain, and that is how we are going to get the posterior pituitary, but the anterior pituitary in this case was derived from Rathke's pouch, and that is why this tumor of the anterior pituitary is going to come from oral ectoderm, that same embryological tissue. Craniopharyngioma is also the most common childhood supratentorial tumor. It's most common in ages 5 to 14. There's a little bit of a bimodal distribution. This is also common in some older adults around age 60, but for kids, it is the most common supratentorial tumor, which is definitely a testable fact on step 1. Usually presents with headaches, bitemporal hemianopia, again, because we can compress the pituitary. We might have hypopituitarism, which is why I have included it on your slide. And when we have hypopituitarism, that's going to present with all the symptoms of hypopituitarism, like decreased TSH leading to hypothyroid, low ACTH leading to low cortisol, antidiuretic hormone being low leading to diabetes insipidus, things like that. But I do want to clarify that craniopharyngioma does not always lead to hypopituitarism. Because this craniopharyngioma can compress the infundibular stalk instead of just the pituitary itself. Remember that infundibular stalk is what is going to connect our hypothalamus to our pituitary, so kind of that highway of communication. This can lead to decreased feedback to the hypothalamus, which in turn can lead to hyperprolactinemia. So in certain cases, craniopharyngioma may actually increase pituitary secretion of prolactin, and so that would not be a hypopituitarism. But I wanted to include it on your slide because in other cases, if it's compressing the anterior pituitary directly, it can cause hypopituitarism. So not a cut and dried clean rule, but usually in the question stem, you'll be able to figure out what this craniopharyngioma is doing based off of the symptoms and lab values. To diagnose craniopharyngioma, again, we can use a head CT. There's usually a suprasellar calcified cyst. If you look over here, you can see this weird thing hanging out right above where our pituitary is, and that's most likely our craniopharyngioma, a calcified cyst showing up pretty white on that CT. You might see electrolyte abnormalities and then a decrease in all the hormones secreted by the anterior pituitary with the variability of prolactin and antidiuretic hormone, kind of depending on if we are pressing on that infundibular stalk or the pituitary itself, and then treatment of our craniopharyngioma is going to be a surgical resection. So I know that was a lot of information. What are some key takeaways that I want you guys to remember from this video? Well, the first thing I want you to remember is that the pituitary is generally damaged by one of two things. Either overcrowding and compression, like in craniopharyngioma, where we have a tumor that's compressing our pituitary, or in empty sella syndrome, where we have CSF that is compressing that pituitary, or it's damaged by a lack of blood flow. And this lack of blood flow can be from hemorrhage or infarction, like in pituitary apoplexy, or it can be from ischemia due to postpartum hemorrhage in the case of Sheehan syndrome. To think about our labs for hypopituitarism, generally think of all of the hormones that the anterior pituitary produces, and then think about what happens when we don't have those hormones, like what happens when we have low TSH. We have hypothyroidism, right? So kind of go through that process in your mind to remember what the symptoms and downstream effects of hypopituitarism. And then finally, imaging can help show us if there is too much CSF in the sella turcica, for example, or if there is a mass, and that can really be your friend when you're trying to figure out which of these causes of hypopituitarism we are talking about. So how do they ask you about this in a board style question? Well, something they might ask you about on step 1 is a question like, a 12-year-old girl presents with headaches, loss of peripheral vision, increased tiredness, recent weight gain, and always feeling cold. Labs reveal decreased TSH, T3, and T4. Head imaging is shown on your slide right here, which embryological layer is most likely responsible for producing this patient's pathology. Okay, so our 12-year-old girl has headaches and loss of peripheral vision. That certainly sounds to me like she could have bitemporal hemianopia. She's always feeling cold, and she's had this weight gain and increased tiredness as well. With decreased TSH, T3, and T4, that definitely sounds to me like she has a hypothyroidism, which would be consistent with a hypopituitarism, right? And then they show us this head imaging, and to me, it certainly looks like she has a mass right above her pituitary. In this setting, it's most likely a craniopharyngioma, right? Because we're having all of these symptoms of hypopituitarism. And she is 12 years old, right in the suspected age range. And then they asked us which embryological layer is most likely responsible for producing this patient's pathology. Because you watch this video, you know the embryological layer most likely responsible for creating a craniopharyngioma is going to be oral ectoderm from Rathke's pouch. And that is how you would answer that question. Thanks for watching this video, and I'll see you next time.